Hi, I'm Mitch Elkind, the Chief Clinical Science Officer of the American Heart Association. And I'm delighted to be here this afternoon to talk with Dr. Lee Schwamm, who's a past chair of the American Stroke Association Advisory Committee. And really what we want to do is just talk a little bit about the last 25 years of the American Stroke Association. So Lee, I want us to kind of put ourselves back, 25, maybe even 30 years ago. What was the care of stroke like back then?
Well, Mitch, I finished my residency in 1995 and my fellowship in 1996. And in December of 95 is when the landmark paper from the New England Journal came out about thrombolysis and alteplase, TPA, and it was approved for use the following year. And we had no stroke system of care. I don't know if you remember, but I'd get phone calls, oh, this is Dr. Jones in such and such emergency room. I have a patient here. I think he has a stroke. They tell me his scan is okay. Should I treat? And we had no organization. We had no data collection. We really didn't know how to transform ourselves from a consultative approach to stroke neurology to a really active and interventionalist approach to neurology. So it was really very arbitrary, very heterogeneous care, and it was completely dependent on who happened to be on call that day. And that's not a recipe for quality.
For sure. So jump forward a few years, 1998, the American Stroke Association is formally named, becomes an entity within the American Heart Association. What do you think have been some of the major events that have occurred since that time in the care of stroke patients?
I think it was an incredibly important move when the ASA was founded, because I think it recognized that stroke was an incredibly important part of the cardiovascular disease spectrum, but it had unique attributes that required specialists outside of cardiology. And so it really created a home for the stroke neurologist. And that role became incredibly important in changing the delivery of care in the United States. So I would say the major accomplishments, if I look back with that lens now, number one would be the creation of a stroke systems of care framework. Number two would be the creation of Get With the Guidelines Stroke to translate evidence into practice. And then the target stroke initiatives that really drove up the rates of thrombolysis and drove down the door to needle times. And then lastly, the policy and advocacy work that has led to formal recognition of stroke centers, state-based certification and recognition of stroke centers, the whole certification process, and ending really in just before the pandemic with the passage of the FAST Act, where we actually got telestroke recognized as a reimbursable activity regardless of the patient's location. Those are really foundational changes to our system of care.
That's such a great summary. I remember back in, I don't know if it was early 2000s, being at the International Stroke Conference. I think it was in Nashville, the Opryland Hotel. And I remember leaving that meeting, and you came out just glowing, because I think it was the first meeting where people really talked about this thing called Get With the Guidelines Stroke. And I remember talking to you and you saying, I have so many ideas. And of course, Dr. Schwamm has been a leader, really a visionary in the development and the use of Get With the Guidelines Stroke to improve systems of care. So I just want to get your perspective on that day. Do I remember that right? Is that how you felt about it?
You do. In fact, I have a photograph that I keep on my desk of the first award ceremony. There were like 6 people there. But we knew we were onto something, because we finally had that magic formula of standardization, harmonization of the effort across multiple societies, recognition, and then that amazing capability to aggregate all that data and start providing insights and published peer-reviewed literature to help people understand how to improve the process of care.
Incredible. So that was, I think, 2003 that Get With Guidelines Stroke was formally launched. A few years later, Target Stroke begins. You were there, I think, at the beginning of that as well, is that right?
Yeah.
Every step along the way. Can you tell us a little bit about Target Stroke?
Yeah, I mean, the amazing thing about Get With the Guidelines was we saw that we could improve 7 fundamental measures of stroke care quality with one intervention, We didn't have to do one at a time, we did all 7. And we were increasing the rate of thrombolysis quite effectively, but the door-to-needle times were totally flat. It was like a 3% improvement per year. And we said, we need to get to the point where we can have 80% of patients who are eligible for treatment treated, and at least 50% of those patients need to be treated within that magic window of door-to-needle 60 minutes. And we really followed in the footsteps of cardiology. This was the same journey they went through with thrombolysis for acute myocardial infarction. And we were able, in the course of 3 years, to get the rate of patients receiving their door-to-needle within 60 minutes to 50%, which was accelerated the expected time by 15 years.
Wow. If
we had continued at the prior rate. And what we learned from that was, again, it's not rocket science. It's focused attention, meticulous attention to detail, and immediate feedback. So you have a case, you do the treatment, you don't hit the target, you understand why. Next case, you try to apply that learning. And that plan, do, check, act kind of IHI, breakthrough collaborative approach has been really successful.
Wow, so real rapid cycle
feedback,
improvement,
exactly.
Innovation. That's phenomenal. And so successful, and then of course it went on to the subsequent target strokes that dealt with thrombectomy as well as thrombolysis, and I think you've been successful in those initiatives as well.
Extraordinarily so,
Yeah.
and the target stroke phase 3 work is now just starting to be analyzed, but we've successively ramped up those targets, so now we're aiming for 45 minutes and 30 minutes for door-to-needle times. And what we find is as we raise the bar, sites respond and are able to achieve those without an increase in harm or risk. So there was a lot of concern there would be excess brain hemorrhage if you rushed too much to give thrombolysis. Hasn't materialized.
And these efforts were primarily in the United States initially, but since then ASA has gone global too, am I right? And we've
absolutely,
moved.
and in a really interesting way, country by country, figuring out what is the best way to partner with local organizations, local stroke organizations, local departments of health, to leverage those resources, provide that AHA science engine, and adapt those to the appropriate environment. So in some places they want literally the whole program because they don't have infrastructure. In other places they want the knowledge, they want the learning. China's a great example. China's done a wonderful job of adapting, get with the guidelines to the Chinese Stroke Association, and they're running those efforts with AHA kind of in a sidecar, helping provide guidance, and volunteer experts like myself and others helping to reinforce the lessons that we learned here. So the impact is global.
It's amazing, and I think we've gone to the Middle East and North Africa, and I think we're going to hear soon about Mexico as well. So hopefully, the rest of the world as well.
And even when we're not formally collaborating, we have created the blueprint and the template.
That's a good point.
And other organizations have adapted our measures as the standards.
Yeah.
And so cross-country comparisons, I think, will increasingly be possible, and they help highlight areas of health inequity, not just in this country, but compared with other countries.
Can we say the same thing about stroke certification? Have we, the ASA has played an important role there?
Absolutely. I think we have demonstrated that systematic, system-wide certification programs are feasible and effective, that coupled with reward and recognition, they are the most successful. We've seen programs launch in Europe. The Angels Initiative, sponsored by Boehringer Ingelheim, is a nice example. Partnering that get with the guidelines recognition approach with the Joint Commission certification approach has proven to be a really powerful combination.
Terrific. So we've talked about the stroke systems of care, we talked about what hospitals can do, certification and so forth. Of course, none of this works if patients don't recognize a stroke when it happens and get to the hospital. Can you say anything about how the Stroke Association has played a role in educating patients to recognize stroke symptoms?
I like to tell the following story, which is when I joined the AHA, when I was first a resident, it was really focused around funding science. And then it began to evolve to convening scientists to write guidelines. But when they put out the 2010 goal of reducing risk by 10% or 2020 goal of 20%, when they put that goal on the ground, suddenly AHA had to rethink their role as an organization. They had to drive change in behavior. They couldn't just publish guidelines anymore. And I think the same kind of framework applies to the public education response. For years we published these long and complicated descriptions of stroke and the 5 suddens and the 6 thises and the 8 that's, and you needed like a PhD as a layperson to understand what's going on. And then we pivoted and we said, what messaging is going to really change behavior? And that's when the FAST campaign was born. And that's simple, it's narrow, it's not overly sensitive, it leaves out a lot of different stroke types, but it really prioritizes patients who are going to benefit from thrombolysis. And so FAST has been, I think, one of the most successful public education campaigns of the Heart Association, quite frankly, and I'm delighted to say that there's a lot of work going on right now in the American Stroke Association Advisory Committee to create a Spanish language version of FAST that is culturally relevant, and I'm hoping that in the next year we'll see that roll out as well.
And just remind our listeners what FAST stands for.
So it's very simple. F is for face, is your face drooping or uneven? A is for arms, does one arm drift down? S is for speech, is the person having trouble speaking or understanding? And the T is time, it's the call to action, it's time to call 911.
Fantastic. A great way to remember the symptoms of stroke and to seek help immediately so that you can take advantage of all the great stroke systems of care that Dr. Schwamm has described. Lee, anything else that you'd like to add in terms of your career? You've spent the last 25 years working to improve the quality of care of stroke in the US, globally. Any final thoughts, anything else you'd like to add about the role of the American Stroke Association in this?
One of the things I love about working with this organization is how patient-centered it is. And I always say this organization has given me way more than I've given it. The opportunity to really meet patients where they are, to try to eradicate health disparities, and to leverage this amazing professional organization to actually deliver on the things you and I value most, that's priceless. So I'm really very proud to be a volunteer.
As am I. Lee, this has been a great conversation. I really appreciate having the chance to talk with you about the history of the American Stroke Association, and I hope you enjoy the International Stroke Conference 2023. And let's look forward to the next 25 years.
Sounds great.